for joining us today. We are fortunate to be joined by Dr. Chitra Bosekar, who is one of our amazing board members here at National Kidney Foundation of Wisconsin. And she will be walking us through understanding your labs in chronic kidney disease today. The way this webinar will run is if you have any questions throughout, please feel encouraged to drop them in the chat or in the Q&A tool. And then Mike or I will come on after the presentation and read them off. The reason we do it that way, though we know it's a bit obnoxious, is because we want to make sure that we're protecting everyone's medical privacy. And of course, any information that you learn today is not a replacement for talking to your healthcare team about your medical decisions. This is for informational purposes only. So with the mandatory disclaimer out of the way, I'll turn off my camera and look forward to your presentation, Dr. Bossekar.
Good evening, everyone. Thanks for joining me today. I'm going to be talking a little bit about understanding your labs in chronic kidney disease. While this is designed as a webinar and a presentation, I really want this to be an informal chat, and the goal is really to get you to understand what all this mumbo jumbo comes down to. And I'm hoping that, it really helps get you more clarity and makes understanding of this a little more easier. So with that, we'll get started. My name is Dr. Bossekar. I am a board certified nephrologist. I am currently working with Amplify Health, which is the former Bellin Health in Green Bay. I serve as a board member for the NKF Wisconsin chapter and also the vice chair for the CKD initiative at WCHQ, which is Wisconsin Collaborative for Healthcare Quality. Additionally, I also serve as a vice president of the medical staff in our Bellin Health or Amplify Health at Bellin in Green Bay. All right, so with that, we'll get started. So understanding chronic kidney disease. Chronic kidney disease, as the name says, it's basically a gradual kidney function loss. So kidneys are basically organs which are located deep inside your abdominal area. They're actually behind, located what we call retroperitoneally. So they don't really fall inside the abdominal cavity, but they're in some ways located behind that entire bag that covers your rest of your belly and the organs in there. So over time, for whatever reason, when the kidney function drops, we have different definitions for when we decide that somebody's got chronic kidney disease, but loss of function gradually over time is called chronic kidney disease. So typically in the United States, the most common reason for chronic kidney disease is diabetes, followed very closely by hypertension. We'll talk a little bit more about the other reasons for chronic kidney disease as well. But for the most part, these are the two major criminals involved with your kidney disease, so to speak. Most patients come to us only in stage 3, and that is because up until recently, we used to have most of the labs which would actually tell us about the kidney function. And kidney function is discussed more with a number called GFR, that is glomerular filtration rate. And a lot of labs would simply report it as greater than 60, in which case we assume that if you do have kidney disease, it was stage 1 or stage 2, but oftentimes we weren't very sure. There weren't really very many therapies in the past, so that's why it didn't really matter if somebody just had a kidney function which was better than the GFR of 60 mLs per minute. For the most part, we tended not to worry about that. That was thing of the past. It's no longer the case right now, but that still continues to be one of the reasons why we see most people in stage 3A kidney disease. So just looking at some of the numbers, I think a lot of people get really worried when we say that, oh, you have stage 3 kidney disease, because for most people, stages are usually similar or synonymous to cancer stages. Cancer has only 4 stages. It's stage 1 through stage 4. And if you are in stage 3, it really doesn't have a very good feel about that. Now, unlike that, kidney disease is actually a huge spectrum. And we have stages 1 through 5, and then you have dialysis. In some ways, I call dialysis as your stage 6 or late stage 5 disease. So, for the most part, stage 3 is bang in the center of the entire spectrum. Not meaning to make this less important, but stage 3 is also pretty huge. It goes between stage 3A and 3B, and we'll talk more about the definitions of all of that. But upfront, what I wanted to do with all of this is basically to tell you that most people are diagnosed with stage 3 kidney disease. Stage 3A, which is the happy part of stage 3, actually has only a 1 to 10% risk of progressing to end stage renal disease, wherein you need dialysis. So, really keeping that in perspective, I am hoping to actually soothe your nerves right off the bat. So, you know that if you have stage 3A kidney disease, the chance that you need dialysis is actually really 1 to 10%. And there's a variation in that. And that depends on how much, some other factors which we should be talking about. So stage 3B ranges from 1 to 25%. Again, only a quarter of those people with stage 3B will go on to need dialysis. Now, stage 4 and 5 are a little bit more severe. That's where 60% or a vast majority of the patients will end up with having dialysis. But again, if you look at it, on the happier side, you have more than 1 in 50% or so which end up on dialysis. So even if you have stage 4, only 1 in 2 patients will end up with dialysis in some situations. But I just want to allay some anxieties which might be right there, because most people come to me and they say, oh my God, if I have stage 3, that means I'm going to need dialysis. Well, hopefully this sets the tone and we shall learn more about all the things going forward. So why all this hullabaloo about kidney disease? If it is really such a slow progression and only 1 to 10% of stage 3A really progresses to needing dialysis, then why are we even bothered so much about that? And that's because, yes, your risk of progressing to needing dialysis or end stage renal disease is really just 1 to 10% with stage 3A. But it also comes, bad things make bad friends. Bad people make bad friends. It's something like that. So you have chronic kidney disease goes hand in hand with chronic cardiovascular disease as well. And cardiovascular disease is basically a whole spectrum of your coronary artery disease, which is your heart attacks, congestive heart failure, atrial fibrillation, peripheral arterial disease, all of that combination. And they kind of march hand in hand. So important to know that stage 3A kidney disease, which we talked about just a minute ago, really has just a 1 to 10% risk of proceeding to dialysis. But it makes really bad friends on the way, and those can kill you. So those can kill you, or those can really significantly cause detriment to your quality of life. So stage 3 chronic kidney disease has 2 times the cardiovascular risk as opposed to somebody who doesn't have chronic kidney disease. Stage 4, there's a 3 to 4% risk of CVD, that is cardiovascular disease risk. And then if you're on dialysis, then it is much higher. It's almost 10 to 20 times as opposed to the general population. So I hope these 2 things actually help you to understand why is it important for us to detect chronic kidney disease, to understand what we can do, what we need to worry about, and what is it that we don't need to worry too much about. So a lot of people will come to me saying, oh my God, am I going to be on dialysis? And the answer is likely not. But that doesn't mean that we stop worrying. It doesn't mean that we stop, taking your doctor's advice seriously about all the other things that need to be done, because we still have to deal with the bad friends that chronic kidney disease brings along. And we need to try and break that friendship up as much as we can. So we need to attack the cardiovascular disease risk by looking at your diabetes, controlling the diabetes, controlling your blood pressure, controlling your cholesterol, stopping to smoke. If you have a weight problem, then dealing with that and bringing that under control, and a few other things. So I'm hoping that this first slide gave you a little idea of where and how we need to focus on things. So let's move on further. So we talked about the fact that there's lots of different reasons why people would have chronic kidney disease. The biggest things, as I said earlier, diabetes and hypertension. Those are the most common times, common reasons for people to come into my office with chronic kidney disease. Apart from that, you have a family history, genetic diseases run in families, like, for example, autosomal dominant polycystic kidney disease, or there might be Alport syndrome, different diseases like that, which run in families, may be something that will cause you chronic kidney disease as well. If you're somebody who has frequent kidney stones, not all of those progress, but a lot of them will end up causing chronic kidney disease. The big ones that I see and I really think is reversible is people who have arthritis and they say, well, my back was really killing me a month ago. I did a lot of gardening, so I took in a bunch of Aleve for about 3 weeks straight, and that will really do your kidneys in. So Aleve, ibuprofen, your Advils and your Motrins and whatever is on the shelf, usually for pain relief, most of those are extremely harmful for your kidneys. So my general recommendation to people, especially if you know that either you have a family history of kidney disease or you have diabetes, you have hypertension, you want to talk to your doctor about what is the best painkiller for aches and pains, how long can I take it, what doses can I take that, and just make sure that you have that discussion. And I would definitely not be taking long-term ibuprofen or naproxen, that is your Aleve, or any of the other medications that are over the counter. If you do find yourself in a bad sticky situation, acetaminophen or the Tylenol, that's what's the brand name that most people are familiar with, those are the ones which are considered to be fairly safe. So acetaminophen is the generic name that is really safe with regards to your kidney. You can go ahead and take that for a longer period of time. That tends not to affect the kidneys as much. If you're smoking, drugs like heroin, all those go on to affect kidneys as well. They do cause kidney disease. Obesity in itself can cause a lot of pressure on the kidneys, and there's something called obesity related glomerulosclerosis, and that is a progressive disease. So it is really important to drop the weight in order to stabilize the kidney function. Frequent urinary tract infections. A lot of times we have people, especially older ladies, who will come to me with frequent urinary tract infections. And not that each of, if you just are somebody who suffers one infection here, one infection there, that's not going to really harm your kidneys. I'm talking about where you just cannot seem to get yourself off the antibiotics. It's like back to back, you get frequent urinary tract infections. Every month you get a one or two infections. Those are definitely something that will cause an increased risk of you developing chronic kidney disease. Autoimmune diseases like lupus or vasculitis, very high risk for developing kidney disease. Fortunately, once you get diagnosed with these, most rheumatologists are very aware and they will be checking your urine very regularly to see if your kidneys are affected. And if they do find some suspicion there, they are pretty quick to refer to a nephrologist. But something that you can advocate for yourself as well, if you do have vasculitis or lupus that runs in your family or in yourself, you may want to just keep a closer watch on your kidney numbers. A lot of malignancies can affect the kidneys. Typically, multiple myeloma is the one that we most commonly see. Renal cell cancer, that is where the kidney organ by itself develops a cancer that can cause chronic kidney disease. But also a lot of chemotherapy medicines that you might use for breast cancer or lung cancer or any other form of cancers do have a way of unfortunately affecting the kidneys. They may not all translate to causing you chronic kidney disease. They may do something called acute kidney disease, meaning it's like saying, well, you went for a run, you slipped and you fell down, and there was a wound on your knee. Now that heals, and then you go on to live your merry life. That's an acute injury, as opposed to somebody who fell down but also had underlying arthritis. Now, yes, the person got up and then he's able to walk again, but that arthritis pain lingers and maybe the fall made it worse. That is what is chronic. That lingers and lasts with you for most of your life. That is chronic. So typically our definition for chronic kidney disease is if you have an abnormality with your kidney function that lasts more than 3 months, then we deem that as a chronic affection of your kidney. So coming down to what are the key labs that we need to look at when we are talking about chronic kidney disease? First thing off the bat that I would want you to know, two things. One is serum creatinine and the other is eGFR. This probably sounds like a lot of mumbo jumbo. Creatinine, so I'm going to explain it in very simple terms, and just bear with me here, for a lot of my analogies are going to be a little funny probably. So creatinine is the trash that floats in your bloodstream. All right. So that is normal. We all have living, breathing bodies. We generate trash just like a living, breathing household generates trash on an everyday basis. Similarly, a living, breathing body generates trash every day. That is because of what you eat, what you drink, what you exercise, your muscle breakdown, on and off, and different things. All right. So that creatinine is not the only trash. It is one of the types of trash that your body generates. We decide to focus on that simply because that is something that we can count. It's very discrete. It is the same in everybody, regardless of which part of the world they came from, what kind of food they eat, and for the most part, with most variations, it remains the same. So, for example, it's like saying if you look at your trash can, you probably find a ton of different things in your trash can. You might find banana peels, you might find fish bones, you might find chicken bones in there, you may find paper, you may find plastic, different things, and you may find soda cans. Let's assume, say, there's some, like maybe banana peels, if you left it really long in there, it might just degenerate, it might kind of melt away. So maybe one day you're going to see only half a banana peel, not the entire thing, or something to that effect. Maybe the bones start breaking down and you don't see exactly how much there was. So what that does is it doesn't allow us to estimate exactly how much trash was there and how much disappeared after it was formed. So we say, that those things don't work for us in terms of measuring. What about looking at soda cans? Let's assume, say, everybody in the world has soda. Okay. So we say, well, if they have 15 soda cans in there, and let's assume, say, a normal is just one or two, then there's a problem. There's a lot of soda cans in there. And let's assume, say, most people cannot consume the equivalent of 15 soda cans or soda cans worth of soda. Then you're saying, well, there are two things that have probably happened. One is that he or she probably couldn't get rid of that trash in time. So why did that happen? Maybe the trash man didn't come or whatever it is. So when you see the serum creatinine build up, one, we are able to measure it. It doesn't change forms. It doesn't become, creatinine doesn't change into a different chemical. So when we measure creatinine, what you generate is what you produce. What you generated yesterday was the same that what we would be measuring. It has a definite a cycling time. So you don't build up that in your body. Your body does not auto produce creatinine. Your body will auto produce certain other chemicals. So, regardless of what you eat or drink, sometimes if your body produces that, then you don't know if there's a problem or if your body is generating something extra. Creatinine is very distinct. Your body does not add more than what normally is formed by the typical metabolism that takes place. And you also don't reabsorb that back. There are some chemicals in our body, like for example, sodium. Depending on what weather conditions you are, your body might decide to reabsorb that sodium back. So that may not be the best way to measure that. Long story short, human beings decided that creatinine was one of the best things to measure and give us a fair idea of what your kidney functions. Is it perfect? No. Is it convenient? Yes. Is it very easily comparable, like your creatinine today versus creatinine yesterday? My creatinine versus your creatinine? Yes, the answer to that is yes. So that is why we pick creatinine. So long story short, creatinine is the trash that floats in your body. So, and the only way for that creatinine to get rid of your body is through the kidneys. So, creatinine cannot get excreted by your bowels. You cannot cry your creatinine out. The only way you can get rid of the creatinine is when you have a functioning kidney. And if your kidney is not working, then the trash level builds up. So, the creatinine levels build up in your bloodstream. So that's the first thing that your kidney doctor will talk about. What is your creatinine? The second thing is called GFR, or glomerular filtration rate. And that is mumbo jumbo for how well is your kidney working. And there's a bunch of different numbers that go into that in order to give you that. So for example, it's like saying, is your kidney working 5% or is it working 100%? How good is it working? So higher GFR means your kidney is working really well, and a lower GFR means your kidney is really not working well. So now you see both these numbers, creatinine and GFR, they go in the opposite direction. High creatinine means your kidney is not working well. High GFR means your kidney is working very well. And vice versa. Low creatinine means, or normal creatinine means that you have really good kidneys, and low GFR means your kidneys are really not working well at all. So hopefully that makes some sense. So they will be going in different directions, typically opposite directions. So if you, like, for example, get admitted to a hospital and your doctors come in and say, hey, your kidney numbers are very high, you can go ahead and ask them, which one are you talking about? Are you talking about my GFR? Are you talking about my creatinine? Because they can be two opposite things that can be explained by saying your kidney numbers are very high. So it is important for you to know that. Now, in certain cases, if somebody doesn't really, so creatinine is a byproduct of your muscle metabolism, meaning whatever wear and tear happens in your body through your muscles, that is how creatinine is generated. In some people, maybe if people have had an amputation or if they've had paralysis, they really don't have much muscle. So they might actually have a very small amount of creatinine to begin with. And that doesn't mean that their kidneys are doing well. It is that rare situation where they are not producing enough. So it's like saying, well, somebody didn't really have soda cans in their trash can. It's that rare situation that that person doesn't have soda, or they have something in a plastic bag, not in a metal can. So you are looking at that and saying, oh, this person has a great kidney function. Well, think again, maybe not. So that is when we go in and get this other number called cystatin C, and that takes away that. Now, according to the latest guidelines, a lot of physicians are actually trying to use this in addition to the creatinine and the GFR, and this gives us a little bit more of an accurate reading, but it also is a little more pricey. So when you're trying to keep the costs down, sometimes that might be a reason why your doctor may not check that. But if for some reason, let's assume, say you are an Olympic level athlete, you are just all muscle all over, then if you came in with a high creatinine, I don't know if it is because you're just generating a lot of trash or if you're actually having a kidney problem. So sometimes in that situation, I will check a cystatin C. You still don't see this very often in most labs, but something which is definitely out there. It is getting more popular, and it is important for you to be aware of. Cystatin C also gives you a reading with a GFR, so it will also be plugged into that calculation for the glomerular filtration rate. So you get a creatinine related GFR or a cystatin related GFR, meaning we talked about the fact that GFR is basically a mumbo jumbo of different calculations where height, weight, and your creatinine and different things go in there to give you a certain number. So instead of creatinine, you can plug in cystatin C, and these are all some things that labs do themselves. You don't need to do anything at all. So they will spill out a number for you and you can take a look at that. So those are the three major things right off the bat that you should probably be aware of, and you would probably have a lot of questions on, I'm thinking. The other important thing that I tend to look at is albumin to creatinine ratio, or a protein to creatinine ratio in the urine. And what this basically means is how much protein is your kidney spilling out. Now, if you think about this exactly, I would give you an analogy of thinking about a coffee filter. When you sieve, or when you put the coffee through the coffee filter, you are supposed to get the concentrate down in your cup along with the water that comes in. If you start seeing particles of coffee in there, there's a problem in your sieve. That sieve is not really functioning very well. So that is something that we tend to measure. Typically, the ones that affect the sieve or the diseases that affect the sieve are diabetes. Some hypertension can cause that as well. Vasculitis can cause that. Glomerulonephritis can cause that. Certain genetic diseases can cause a lot of protein in the urine as well. Now, that is not a very good thing because when you have a problem with your sieve, that means we're looking at some bigger problem. And there is a lot of studies to show that amounts of protein in the urine actually correlate with the disease burden, how rapidly you progress to needing dialysis, how much heart problems you develop, as well throughout your journey with chronic kidney disease. So most people come and ask me, oh, he or she is losing protein in the urine. That means, do they need to supplement more protein? And if you think about it that way, that's probably not correct. The amount of protein that you see in the urine is really very small. You are not going to get malnourished because you are putting that amount of protein in the urine. Now, I would say there are exceptions to that. There are some people who dump a ton of protein in the urine. That's a different story. But for the vast majority of people, whatever protein you lose in the urine only is telling me that there is a problem with your kidney, but it is not causing you to be malnourished. It is not causing you to lose protein significantly from your body. It's like saying, well, you dropped a few pennies off your purse, but that doesn't really indicate that you are going to have to really go to the bank and withdraw a lot more money. It just gives me an indication that your wallet is probably old or your coffee filter is old, but it's not something that I need to think that I need to replace a lot more of. And that comes and brings us back to the fact that maybe you have to talk to your doctors about how much protein should you really have in kidney disease. And the reason I'm bringing this up right now is just because this lends itself to that myth that, oh, since I'm losing protein in the urine, I need to pump more protein into my body. And that's not quite correct. Each person is different, but for the most part, we tend not to have you push too much protein when you have chronic kidney disease. So the protein in the urine just gives me an idea or an indication that your kidney has a problem with the sieve. So we divide it into three different categories. 0 to 30 is considered normal. A lot of people come to me with that. There are people who have moderate proteinuria, which is 30 to 300, and then there is greater than 300, which is considered severe proteinuria. So then people get confused about, well, what is protein creatinine ratio and what is albumin creatinine ratio? So you have a lot of different proteins that can actually be found in the urine. But the one which is very specific for damage to the sieve is the albumin. The rest of the protein, you have albumin, you have globulin, you have different other proteins which falls into the urine. The globulin is not that important, or if it is in there, it might be indicative of a different kind of problem. The one that I'm focusing on, for the most part, I want to see what is the albumin level in that urine. And we compare that to how much creatinine you're secreting. So it gives me an idea and it relates it to the kidney function as well. Because what if, because somebody's kidney function is low, they are not, you can think that the math might be off in there, that maybe they are looking like they're putting more protein in there, but it's not actually true. So we actually try to take away the relation of that kidney function to what is coming out by saying we're going to divide it by the creatinine in the urine, and that gives us a better idea. So we talked about four things. We talked about creatinine, trash levels in your bloodstream, higher levels of trash, poor function. We talked about GFR, that is kidney function. For the most part, I equate it to a percent scale, starting from 0 to 100. Normal kidney function is closer to 100% ballpark. It's not exactly the same that way, but it helps to think about it that way. So your eGFR, if like, for example, you are say stage 3A, you would have say 58 mLs per minute of GFR, which is similar to saying that you have a 58% kidney function. It's not exactly the same, but it helps and it's kind of similar in that sense. And then there is cystatin C, which is another type of trash that is measured, more sensitive. We're not using it on all patients. Guidelines do say that we should use it, but a lot of people are still holding back on that because the cost is pretty high. So some people don't, some people do. I just want you to know that. The other thing we talked about is albumin to creatinine ratio or protein to creatinine ratio. And that gives me an indication of how is the sieve of your kidney or the filters in your kidney. Are they having holes in them? Are they causing loss of protein, which is not a good sign? So I am hoping that that really makes some sense. In addition, a kidney doctor also looks at your electrolytes. We look at, I'm sure you, if you are somebody who has either kidney disease or some near one, dear one who has kidney disease, you might have heard about the fact that, oh, his sodium is high or his potassium is high or phosphorus is high. So we look at all those things as well. Measuring the electrolytes and the hemoglobin helps detect complications of chronic kidney disease, such as imbalances and anemia. And we can talk more about that in the next few slides. So I think I already talked a lot about the EGFR, that was the kidney function. And based on the EGFR is how your kidney disease is divided into stages. So stage 1 is when you have greater than 90 mLs per minute of GFR. So think greater than 90% kidney function. Stage 2 is 60 to 89 mLs per minute of GFR. Think 60 to 89%. Stage 3A is 45 to 59. Stage 3B is 30 to 44. Stage 4 is 15 to 29. Stage 5 is when you actually drop your kidney function below 15 mLs per minute. Think below 15%. Most of the time, when people are around the 10% ballpark, it's not an exact line that is drawn. It's not that every person who has 10% kidney function will be started on dialysis, but somewhere in that ballpark is where people start dialysis. A lot of people do exist in stage 5 kidney disease and do not need dialysis for several years because they've managed their risk factors very well and things are pretty stable. So it's like thinking your airplane is flying very close to the water, but it's stabilized itself. So it's parallel to the water, very close to the water, but it's not hit water. So don't give up hope. Even in stage 5, there is a very good chance that you can actually stay even for several years. So as I said, dialysis is usually when people hit the 10% or 10 mLs per minute GFR ballpark. We don't look just only at the GFR, we look at multiple other things. We look at your electrolytes, we look at how well are you getting rid of all the extra fluid in your body. How well are you getting rid of the acid levels in your body and different other things as well to understand when and whether you need dialysis at that time or can we push it off some more. All right, the other thing that you probably will see and hear about is BUN, that is blood urea nitrogen. And this, remember we talked about the creatinine. So blood urea nitrogen is another form of trash that floats in your body. Unlike creatinine, though, there are a lot of things that can affect blood urea nitrogen. Disease states can affect. If you're dehydrated, your blood urea nitrogen can go up. Not necessary that your kidney is not working. It's just that you are dehydrated, so your number went up. Some medications can cause your blood urea nitrogen to go up. So that gives me some clue, but it is not perfect. That is why we don't use it all the time. But it's also important to understand that when blood urea nitrogen does go up, we think, not quite sure about this, but we think that that gives you a lot of symptoms of kidney disease, or rather advanced kidney disease. Like, for example, when your blood urea nitrogen gets to maybe even 100, somewhere in that ballpark, most people will start having symptoms of nausea, meaning your body is telling you, I can't get rid of the trash. Don't put anything more inside me. So hence the nausea. That's vomiting can happen as well. People complain about itchy skin. That's because the trash levels get underneath the skin and cause problems. And that causes you to feel itchy. People have headaches because the blood urea nitrogen levels get up pretty high in your brain, and that causes headaches. People have disturbed sleep or horrible dreams, again, from the fact that there's a lot of trash floating around in there, which causes that. So we think that the blood urea nitrogen gives you some symptoms. Not everybody seems to have the same symptoms at the same levels, meaning there are some people who will tolerate a blood urea nitrogen of 200 without blinking an eyelid. And there are some people who are at a blood urea nitrogen of 50 and they are just miserable. So it's just all over the spectrum. So that is one of the things we look at, not the only thing. It helps us to understand where your kidneys are and how they're functioning and what can we attribute this to, or what is it that may be explaining some of your symptoms. Each lab has slightly different values. So typically it is under 30 milligrams per deciliter that is considered normal. So when you get your labs, you can look at the reference range to understand where you are with that. I wouldn't put too much stock into that. I would definitely talk to your nephrologist or your regular doctor about, his number is looking like it's, let's assume, say 43. Is that something that I need to worry about? Do you think that is explained by something else? Is that something for us to take a look at and do something differently, or just leave it alone? And I'm sure you'll get some answers from your nephrologist or your regular doctor about that. Um, and then also blood urea nitrogen levels can be affected by liver health as well. So that's another reason why we don't look at that exclusively for kidney disease. And we talked about causes of abnormal BUN levels that can be dehydration, kidney disease, liver problems, steroid use, certain medications like Urena that is used for controlling the sodium levels. Those can cause that kind of problem as well. So we already talked a lot about creatinine. I mentioned that this is a waste product from your muscle metabolism, typically around 1 milligrams per deciliter. Again, every lab is a little different. You can look at your lab reference ranges to understand where you are. I don't tend to see levels beyond 4 to 5 in the clinic. Once you're on dialysis, you may see higher numbers. That's again not unusual. So a lot of people will come to me and say, hey, my husband or wife is actually on dialysis. So why is their creatinine this high? Because, dialysis, remember we talked about the fact that creatinine is one type of trash that we generate. The dialysis works in slightly different ways. It does move the creatinine and pulls that out as well, but there's lots of other things it does. So it may not always correlate. Once people start dialysis, we do not look at these numbers anymore. We understand that that is being done differently, and we have to look and understand dialysis a little more differently. So again, how to explain this a little better, it's like saying, normally, let's assume, say you look at the trash cans in your garbage can to understand how well trash is moving in and out of your house. But at some point you decide, you know what, I'm going to get an external service to clear that up, and they're going to make some changes. And let's assume, say, they have a chute where they can actually move this out, but the trash cans, the chute doesn't move creatinine that effectively. So you might still see some, but for the most part, your trash is moving out through a slightly different method. So we tend not to worry too much about BUN and creatinine once you're on dialysis. Important thing to know, because a lot of people do get very upset when they see high numbers in there. Doesn't mean that dialysis is not doing anything for them, just means that things move differently. It is normal to have higher levels when you're on dialysis. And also remember, dialysis is man-made or woman-made. It's not half as good as what the Lord blessed us with. So our kidneys work every second, every minute, 24 hours a day for your 100 years of life that you are alive. Your dialysis happens only for about 3 to 4 hours every other day. It's nothing compared to what your kidneys can do. It's good to keep us alive. It is a great invention, but really it's not a comparison to your normal kidneys at all. I think that's all I have on this slide. Let's go to the next one. We talked about the microalbumin creatinine. I just put a picture of the sieve so you can understand. Now, if there was a big hole in that sieve, you would see a lot more of whatever you were trying to keep on this side of the sieve down into your coffee cup or anything. We talked about the fact that elevated albumin creatinine ratio is an early indicator of kidney damage, especially in individuals with diabetes, high blood pressure. Sometimes that's the only thing that is abnormal. Your creatinine might be okay, your GFR might be okay. So that tells me that the kidney is doing a good job at getting rid of all the trash. That is fine, but it is struggling. So, how I explain that to people is you have a trash can and let's assume, say, you got a trash can from Walmart. It was supposed to be a 20-gallon trash can, and you look at it and it holds 20 gallons really good. But if you have a brand new trash can, it looks really pretty on the outside as well. It's got a fresh coat of paint, it's got no rust anywhere in there. And then you look at another trash can, which holds 20 gallons of trash, but let's assume, say, the paint is starting to wear off, or metal around that is starting to rust. And that tells me that there is problems. And if you don't address that, maybe a year or 2 years from now, that trash can is going to develop a hole. And now it will no longer be able to hold the 20 gallons. It might be able to hold only 10 gallons or something like that. So that is what that albumin in your urine signifies. It signifies that there is a problem. You need to attend to it right now, but it is not something that is going to cause you to die this minute. Your trash can looks ugly, and sometimes you just leave it looking ugly for a little while, but it's not going to cause you problems. But if you have a trash can that is leaking, that is a problem we need to attend to immediately. So, just again, putting things in perspective. So then the next big thing is potassium. And potassium is again another chemical in our body that is generated typically because of all the foods that we eat. All your oranges, tomatoes, potatoes, watermelon, they're all pretty high in potassium. And our body is such a wonderful unit or mechanism, you can say. It really keeps what it wants and gets rid of the things that it doesn't want. So let's assume, say, it was watermelon season and you decided to go trigger happy with watermelon. You're going to be having 2 or 3 watermelons. Your body does not need that much potassium. Potassium is a chemical which is great for your body, but it can be dangerous on both sides. Low potassium can cause a lot of different kinds of problems. High potassium can cause a lot of different kind of problems. So your body actually narrowly regulates potassium to stay between 3.5 to 5 milliequivalents per liter. And in order to do that, it needs to sense how much potassium is coming in and then have a way to get rid of the extra that is coming in as well. So one of the ways in which the body gets rid of potassium is through your kidneys. In fact, kidneys get rid of 90% of the extra potassium in your body. The remaining 10%, you can be pooping those out. You cannot cry your potassium out. You cannot sweat your potassium out as much. Yes, if you ran a marathon, you would be depleting, you would sweat out a lot of electrolytes, but nothing compared to what can happen when your kidneys just lose potassium. Now, there are genetic diseases where there are some people who just cannot hold potassium. Their kidneys actually get automatically leak potassium out. Now, that is not a very common problem that we tend to see, so we're going to not talk much about that. For the vast majority of people with chronic kidney disease, if your kidney is not functioning, that is your bottleneck for potassium to get out of your body. That means your body is unable to get rid of that potassium that comes in very rapidly. So that is why you will probably hear all of us kidney doctors talk and wax eloquently about the fact that please limit the potassium in your diet. When you have a kidney that is not working very well, it's working, let's assume, say 15 to 25%, your body cannot handle that extra potassium load that comes in. Oftentimes, that is one of the reasons why we have to start people on dialysis, because the rest of the numbers are not too bad, but they're just not able to control the potassium that is coming in. And there is no way for that potassium to go out. And at some level, if that potassium level builds up, it will cause heart problems. I'm not talking about blockage in the heart, I'm talking about arrhythmias. So you can have ventricular fibrillation, atrial fibrillation, just different kinds of arrhythmias which are exceedingly lethal. And that is why we really tend to worry a lot. That is why some of you might also experience this nasty thing where you get your labs drawn and they get resulted at about 10 o'clock at night, and then somebody calls you panicking at 11:30 at night saying, hey, your potassium is 7.5, you need to go to the ER right now. Just to give you an understanding of why that is done, why that happens, it's just one of those things. So people with kidney disease must really regulate their potassium levels to avoid the health risks from the impaired removal. Risks of hyperkalemia. Hyperkalemia is mumbo jumbo for high potassium. That can trigger dangerous heart rhythm disturbances, posing major risk for kidney patients. And as I said, the therapeutic window or the levels which your body really likes is 3.5 to 5. That is your normal range. Typically, if you go above or below, it's not a good thing. If you go below, I can have you eat a lot of oranges or watermelon or even give you potassium pills. I can get it up for the most part quite well. Getting rid of the potassium makes it a lot more challenging, especially when you have a kidney that is not working well. So then I have to really hammer the kidney hard with certain medications, which can make things a little bit more harder and harsher for that kidney. So really important to regulate your potassium. Having said this, I also want to say that if you are somebody who has early kidney disease, let's assume, say, stage 2 or even stage 3A, and potassium has never been abnormal for you, I don't want you to be restricting potassium. If you are not somebody who seems to have a problem getting rid of the potassium, then please enjoy your watermelon, please enjoy your oranges, please enjoy your mashed potatoes, because those are also healthy. I would rather you eat watermelon than having croissant or chocolate brownie or something else all day to curb that sweet tooth. So potassium is great for you, and I want you to enjoy that and I want you to have that. But as you advance in kidney disease, maybe you should discuss that with either a dietitian or your doctor to understand, are you somebody who needs to restrict potassium or maybe not? And we should probably restrict things only if it is a problem for us to get rid of higher levels. And your body will tell you that. So talk to your doctor before you blanket decide to restrict potassium. Restricting is not important for everyone. It's usually in the late stages, late stage 4 or stage 5 is when I usually start hammering that down. Very few people with stage 3B, I will tell them to watch their potassium. So it is really important that you talk to your doctor about that. The other number that we look at is also bicarbonate levels. And bicarbonate is actually an alkali. And the problem which occurs with kidney, or rather one of the things the kidney does really well, is getting rid of the acid that your body generates. Now, where does this acid come from? Anything and everything we eat generates a lot of acid. A lot of meat products actually generate very high amounts of acid load. And in order to get rid of that, the kidneys are one main organ to do that. So oftentimes when your kidneys are not working well, your body is not unable to get rid of that acid very well. So what is all this got to do with the bicarbonate? Sorry, my dog is having a little meltdown here. I hope you can't hear him. So bicarbonate is something that neutralizes the extra acid that is present in your body. And so when you have high levels, normal levels of bicarbonate, and your acid keeps building up, the body pulls that bicarbonate to neutralize that acid so it doesn't cause problems to you. So as you progress with kidney disease, you will see that your bicarbonate levels keep dropping. And that's because a lot of that is getting pulled in to neutralize that extra acid, which is unable to get excreted by your kidneys, which are not working well. So bicarbonate acts as a buffer and is essential for maintaining that acid-base balance. Range is typically 21 to 32 millimoles per liter. In chronic kidney disease, as I mentioned, kidneys cannot excrete that acid, so they basically cause acid buildup, and that pulls more bicarbonate to neutralize that acid. Beyond a certain point, it is unable to do that. So that's when your body goes into a critical state with too much acid in there, and that can cause problems with breathing and different other things. But at low levels of acid production, what really is the big thing we worry about is bone loss. So again, think about putting a chalk in container of acid. It will dissolve over time. So that's like saying you put bone in a cup of acid. It is going to dissolve or get really weaker with time. Now that is really low levels of acid which cause that, and we try to neutralize that as much as possible. And that is why some of you might be prescribed sodium bicarbonate pills to take when you have more advanced kidney disease. But for very high levels of acid or very low levels of bicarb in your body, typically that is a medical emergency. You may need dialysis, but at least you will need to go to the hospital in that situation. So what you see in your lab result is the bicarbonate level. So you see low levels of bicarb, and that means that your acid level is high. We're unable to measure acid levels in your body, so we measure a proxy bicarbonate. And if the bicarb is dropping, it means that it is getting pulled out to neutralize that acid in your body. And beyond a certain level, it cannot go down any further. And then we probably should talk about hemoglobin. And that is, again, something that a lot of you will have had some experience with. As your kidney disease progresses, it seems to cause some damage to, or I wouldn't say damage, it causes some related abnormalities of your hemoglobin. So kidney lives inside our body, and if one organ goes down, it affects other organs in some ways. So when the kidney goes down, it affects the bone marrow in some ways. Turns out that you need normal functioning kidneys in order to give the bone marrow a kickstart to actually having normal blood cells being produced. So for whatever reason, people with kidney disease seem not to absorb iron very well. That is the first problem. And then the second thing is their bone marrow doesn't seem to produce. Even if you give them enough iron, it just doesn't seem to want to work. It's almost like the bone marrow saying, kidney isn't working. Why am I being asked to work? I'm not going to work either. So when we keep a watch on that and we tend to see where your numbers are, and typically if you tend to fall below 10 grams per deciliter of hemoglobin, then your doctor will be checking you for any deficiencies in B12, iron, folic acid, and if there is some, he will replace those. But if everything looks normal, then he might ask for you to get a shot every month, which kind of kickstarts your bone marrow to producing more of that hemoglobin. So normal hemoglobin is 13.5 to 17.5 grams per deciliter. Again, look at your reference ranges in your lab. Everybody might be a little different. And hemoglobin is important because it carries oxygen throughout the blood. So if your bone marrow doesn't produce these red blood cells and the hemoglobin, then you have a problem transporting oxygen. So your body just gets tired. That's what happens when people have anemia. So we do need to address that in people with chronic kidney disease. And then again, kidney doesn't work in isolation. For whatever reason, it seems to affect the calcium, vitamin D as well. And you might also have heard about hyperparathyroidism. Parathyroid is a gland that sits in your neck. And the only reason it is called parathyroid, firstly, it's got nothing to do with the thyroid. Parathyroid means it sits by the thyroid gland. It's a neighbor of the thyroid gland. That's all that it's got to do with the thyroid. Nothing else, nothing related to the function. So if your thyroid is not working well, that's got nothing to do with your parathyroid. Parathyroid, four glands which sit on either side of your neck, close to the thyroid gland. And their job is actually to maintain calcium levels in your bloodstream. So what these glands do is they sense constantly how much calcium is floating in your bloodstream. And again, calcium is another chemical similar to potassium, which has a very narrow window. So you constantly need to sense and adjust how much calcium there is. Now, unlike potassium, which comes largely through the diet, what the parathyroid does is it says, hey, I am not going to wait for any diet. I'm not waiting for anybody to drink their milk or take their vitamin D or their fish oil. I am just going to reach out into my vault and get that extra calcium. The vault is your bone. So that means if the parathyroid senses that the calcium levels are running low in your bloodstream, it reaches out to to the vault, into the vault, and pulls calcium from there and puts it back into your bloodstream. Now, for whatever reason, when the Lord designed us, He made the sensing loop run through the kidneys such that if your kidneys don't work well, the parathyroid cannot sense how much calcium there is in your bloodstream. So it kind of gets a little more finicky and panicky, and it keeps reaching out into the vault thinking that there is not enough calcium in your bloodstream. So the parathyroid goes really crazy, goes up very high, levels rise up very high in people with kidney disease, and then keeps pulling that calcium from your bone. When you don't address that, that causes bone loss, it causes, fractures and all that stuff. You don't want that. So typically what we tend to do is we say, hey, parathyroid, we know that there is no problem. We're monitoring this patient. He or she gets their labs done every so often. We can see calcium levels are okay. You do not need to do this. You do not need to reach out into the bone. What we're going to do is we're going to really calm that parathyroid by giving it some extra vitamin D. Now, there are different medications out in the market for this. So we can use all of those to kind of tamp down or calm down that parathyroid so it doesn't go crazy on you. So that's a little bit about that parathyroid, calcium, and vitamin D and how they're all involved in this. So similarly with phosphorus, phosphorus is another chemical that only your kidney can get rid of very effectively. You can get rid of that through your bowels as well, but not as effectively. So when your kidney doesn't work, phosphorus levels go up a lot more. And phosphorus is one chemical which doesn't really get cleaned out very effectively with dialysis. So that's something that we will always be hammering you, saying that you need to really limit the phosphorus in your diet. And we give you binders when you are on dialysis. For the most part, even a little function of kidneys does a good job in clearing that phosphorus out. So when you have chronic kidney disease, phosphorus is not so much of a problem. When you're on dialysis, a lot bigger problem because your kidneys are just not working then at all. And dialysis doesn't remove that as well. So again, talk to your doctor about your calcium and phosphorus levels and parathyroid, and they will be able to help you to understand that a little bit more. So that's what we talked about. Phosphorus around 2.5 to 4.5. The only way to get rid of that is largely through the kidneys, to some extent through your gut as well. Unfortunately, phosphorus is something that is there in a lot of preservatives, a lot of processed foods. So it's kind of hard to really keep that. But our dietitians are amazing at giving you a very good idea of what foods have that, how can you limit the amount of phosphorus, what can you do to get rid of the phosphorus in some of the common foods and stuff like that. And then we also talk about A1C targets. A1C is a measure, you probably are familiar with that. That's mark of how well is your diabetes controlled. So typically we like for people with kidney disease to be a little under 7% for their HG, hemoglobin A1C. Now, there is also, everybody also knows that people with kidney disease tend to have more problems with dropping sugars because some of the medications that are used for diabetes, not insulin, but the oral pills, they actually linger in your bloodstream a lot longer because your kidney is not getting rid of that. And sometimes there can be dose stacking that happens, and that will cause your blood sugars to fall down a little bit more. So you have to be careful with that. But on an average, we like your numbers to be closer to 7% or lower for really making sure that the kidney disease doesn't progress very rapidly. And this is again important. You need to discuss this with your primary doctor so you can understand exactly what are your risks with tight control of that blood sugar. And then we come down to blood pressure. What can we do with blood pressure goals? And typically we like it to be somewhere between 120 to 130. For some people, I will target levels less than 120. And I always tell patients, this is not about me just chasing a number because it doesn't make me happy if you're going to pass out on your front porch with excellent kidneys, kind of defeats the purpose. So I want your numbers low, but I also want you to have a good life. So if you are dizzy, you are lightheaded, you don't feel very good, that's not a deal. Then that blood pressure is not working for you. But let's assume, say, your kidney numbers are consistently going down and your blood pressure is 140, 150, then we really need to tighten that. And we need to get that to as low as we can tolerate that. And typically for people with kidney disease, if you're a diabetic, we target you to just less than 130 by 80. If you are somebody who doesn't have diabetes but kidney disease, we like you to go even lower than that. And that is assuming that you are tolerating that well without side effects. No doctor wants you to have side effects, including me. So yes, we do have targets. It's like saying, well, I'm going to put a goalpost somewhere. I want you to get to that goal. Even if you run towards the goal, you've made progress. And I don't want you to reach the goal and pass out. That's no fun for anybody. So we want to make sure that you know where the goal is and that we want to keep egging you on towards that goal. And then finally, this is the heat map. That's what we call, this is the chronic kidney disease heat map. And as you can see on the x-axis, that's your horizontal line of reference there. You have three numbers. You have the less than 30, 30 to 299, or greater than 300 milligrams per gram. That is the level of your protein. And on the y-axis, that's your vertical one, it says G1, G2, G3, A3, B4, and 5. That is the stage of the kidney disease. G stands for GFR, and A stands for albuminuria or the proteinuria. So we kind of plot all people based on their kidney function, how much protein they're secreting into this green, yellow, orange, red, and deep red areas. And that tells you what is your risk for complications, what is your risk for progressing to dialysis. Pretty much that is the main thing in that. So as you can see, if you are stage 1 and if you have no proteinuria or less than 30 milligrams, you are green. You are actually pretty safe. Even stage 3A, if you have no protein, then it's a mild yellow. We'll slow down, we'll take life easy, we'll see what's coming our way, but we are not in any kind of panicky zone. But as you go towards the bottom of the chart and to the right side, things are getting a little bit more hot and ugly, and you want to try and move yourself towards the top of that screen and towards the green zone. Again, this is something you can take a look at your own numbers and see where you land and see what is it that you can do to move yourself towards the happier parts of this chart. And then, we kind of intertwined all of this during the entire talk itself. We talked about potassium levels, the BUN creatinine, hemoglobin, phosphorus, calcium, PTH. And these are all important differently in people on dialysis. We also talk about fluid removal rates and weight gain. That's another number that we look at. So your doctor will always tell you, I don't want you gaining too much weight on dialysis. You want to make sure that you drink no more than 1 to 1.5 liters per day, no more than that, because beyond that, it is very hard for the body to deal with the ups and downs of taking so much fluid off. And then we also talk about blood pressure in patients with dialysis. And I think that's all I have for you. And I hope that